The following program has been made possible by an educational grant from Bayer Healthcare Pharmaceuticals, Inc.
Welcome. My name is Dr. George Kraft, and I'm the host of this 9-part series on multiple sclerosis. We call this MS from A to Z. These shows are produced in the studios of UwTV in Seattle, Washington, and are available on UwTV in the Seattle area and on the Research Channel worldwide. And for those of you who don't have access, you can go to the UwTV website, which is on the screen. And if you forget that, you can just Google UwTV and put in there, search for MS from A to Z, and the shows will pop up and you'll be able to click on them and learn. I view this 9-part series as a college course that we are bringing to your home to inform you about multiple sclerosis. And I look at MS as I might look at an iceberg. And the iceberg you see above the water is what you see. And that's people talking, and that's people walking. But you know, 90% of that iceberg is below the surface, and at least 90% of MS patients' problems are below the surface and not really apparent to you. Problems such as fatigue, the most common symptom of MS. We've already had a show on that. Pain, very, very common, very prevalent in MS, and it doesn't show. People don't know you have pain if you have MS. We've had a program on that. We've had a program on cognitive impairment tonight, which is a very important part of MS. You know, MS affects the brain and the spinal cord, and how could a disease affect the brain without impairing the thinking process or cognition? So I'm very pleased to host this show on cognitive function in MS. And we have 2 experts from the Western MS Center in Seattle, Dr. Mary Pepping and Dr. Myron Goldberg. I'm going to ask these experts some questions, and I hope they'll give us answers which will be meaningful and helpful to you. I think the first question, Dr. Goldberg, is what is cognitive function? What is cognitive impairment?
Well, first of all, Dr. Kraft, I enjoy your example about, an iceberg. And cognitive functioning is definitely one of those factors underneath the surface of the water. And what we mean by cognitive functioning is our thinking abilities. Just as we're doing now, how we're paying attention, what our memory is like in our everyday life, problem solving. It's those factors that we take for granted until we have problems in those areas. Mm-hmm. So it's our general everyday thinking abilities.
Mm-hmm. How prevalent is cognitive impairment or some dysfunction of thinking process in multiple sclerosis?
Well, it's been studied a lot in the literature, and I think we have to step back as one step and ideas about how we know about cognitive functioning in any individual. And in one way is just to ask the individual in their self-report, or ask their significant other or a friend about how they're doing it. But another way in which a lot of the studies are based on, in which we get some idea about how many people have cognitive functioning, is something that we do called neuropsychology, neuropsychological evaluation. And that's what Dr. Pepping and myself do. And a neuropsychological evaluation is one where it allows us to objectively look at someone's cognitive functioning, as well as emotional functioning. So we're going to look into a lot of different areas, a lot of different thinking abilities in a very systematic, objective way that gives us an idea about its strengths and weaknesses. And we're very fond about talking about neuropsychological evaluations, and that they take several hours to do. But that's the way we know about an individual.
How many hours is several hours?
It's a good question. It can vary, but generally it'll take at least 3 or 4, and sometimes up to 7 hours,
You
depending
know,
on what we want to get at.
My MS patients have fatigue. That's their most common problem. I think that if I had a patient take a test for 4, 5, 6 hours, they would be fatigued. I think I would be fatigued, and I don't have MS.
Right.
How do you get around that in the
I
MS
think it's something that
population?
myself and Dr. Pepping, we face all the time in that sense. And we like to divide the tests up. And if a
Different days? For
different
example?
days, and the person can take rests. And we generally say that if a person's coming in for a neuropsychological evaluation, they are in complete control. That is, they can take the rests and tell the person administering the test, wait, I can't give my full oomph to the test and I need to take a break. So we will be fine about breaking it up. And sometimes we'll shorten the test based upon their fatigue levels also.
This strikes me as something that might be really expensive, because if you have, let's say, 6 hours of a technologist's time in a room scheduled to do testing on a patient, that's the better part of a workday. And if the patient can only do 2 hours, I mean, how do you handle the economics of this? It must be very expensive to do this.
Yeah, most of the time a neuropsychological evaluation is funded through insurance and can be reimbursed that way and such. I think it's a thing that, you know, the individual, the care provider, the insurance company looks upon it as its benefits, even though that may be expensive. There's a significant amount of benefit to know about a person's strengths and weaknesses, and then you can identify treatments that might be effective that we'll talk about later on, as well as what they're ready to get back to in their daily life. And so there's an upside to doing an evaluation, and they can be relatively expensive, but they're typically funded by or reimbursed through insurance.
You know, you mentioned in passing depression, and that is one of the really important parts, another part under the surface of the water in the iceberg. I would think that depression might, if somebody's depressed, they might be fairly bright and still maybe just not feeling they could answer the questions. Do you see that on your testing, and how do you separate that component? How do you separate the components, the fatigue, the depression, from the cognitive impairment component?
I think that's one of the reasons why we want to do a neuropsychological evaluation. The word neuropsychological spans a broad scope of things. It's not just about a cognitive functioning assessment. It's also about emotional functioning. All the different factors in a person's life, not just depression. It could be anxiety, host of factors, or stressors in their lives. All those things need to be taken into account when we start thinking about a person's cognitive functioning. It may not always be the disease process itself, but all those other factors that the person is facing just in general life, and how it's, what those effects may be on cognitive functioning. So a neuropsychological evaluation, I think, is one of the tools that we have to help sort out those factors that all could be influencing a person's cognitive functioning. And some of those factors can be very much treatable. So if it's depression, sometimes fatigue, sometimes stressors in the life, we can separate those out in treatment and try to make some impact, and at the same time improving a person's cognitive functioning.
You know, this goes along with my philosophy of treatment of MS patients in the Western MS Center, is that what frequently occurs is there may be one thing that stands out, like maybe depression. And you just treat that alone. Well, you know, you have to treat the fatigue, I believe. You have to treat the depression. You have to treat the pain if there's pain. Pain can interfere with functioning. And you have to do what you can do to manage and treat the cognitive impairment. I really think that the care of MS patients really requires a team approach, and isn't something that is easily given in a private office, really. So I'm thinking that you have to know about MS to know how to do really quality cognitive assessments in MS, don't you? Because if you just routinely did neuropsych testing and didn't appreciate all these undercurrents, so to speak, in MS, you might get false information.
And people with MS frequently can score very, very well on many of the measures that have to do with intellectual functions or structured memory or basic attention. You can put them through kind of standard items and they look pretty good. But unless you dive in deeper and look at other features that I know Dr. Goldberg is going to say more about, unless you really choose instruments to go after the more subtle complex disruptions, you may not be able to appreciate what's going on under the surface.
I think that's really, really an important point to stress. And I think that means that you really don't want an MS patient to get a neuropsychological evaluation unless it is really given by someone who understands the disease and can, as you say, maybe sort out the other things and take advantage of appreciating all of the things that are happening under the water surface in MS. Would you hazard a guess, Dr. Goldberg, as to what % of people with MS have cognitive impairment? Before you answer, I'm going to tell you what I think. I've tried to find this answer in the literature, and I really have, and I've been at this for some years. And what I find is that it depends on the population you examine.
It's a very elusive answer.
It's very elusive.
So in some of the studies, the researchers will go to a nursing home and pick out all the MS patients and give them cognitive assessments, and of course they may not do very well. So the other way of doing it is doing it in a cross-section of the population, people who are living at home, people who are functioning. And if you may find that many of those aren't doing all that well, but they're functioning very well in their community because they've learned to adapt and modify how they handle their life and their job and their family situation.
Absolutely.
But could you give me some range of numbers, would you mind?
You're making my job so easy, Dr. Kraft, because you're right. When you look at the literature, it has a broad range. And one of the reasons I wanted to step back a moment to see how we learn about cognitive functioning and talk about neuropsychological testing or evaluation is that many of the studies are based upon neuropsychological evaluations. And I think they provide us some objective information, but it so much depends on who you're testing, who the sample is, and such. So
And
it's
what
a lot
instruments.
and what instruments are being used.
Would you
So-
define an instrument? Like a machine or something?
No, not like
All
a
right.
machine. Not like a
Maybe
machine.
define
Yeah.
what you're talking about.
Yeah. An instrument is one of our tests that
Okay,
we use.
so it's
So
a
it
test.
could be like a word list that we give to somebody.
These are paper and pencil tests? They're oral
and pencil
tests, or?
Oral tests. They could be drawing something. Could be a problem-solving test, and so forth. So that's what we mean.
And
by
you can test
instruments.
people with visual impairment, because many MS patients have optic neuritis. So you can get around if they can't read or can't see, you can get around that.
Yep.
Yeah. And neuropsychologists who are experienced in MS will try to pick out those instruments or tests that have been shown to be pretty sensitive to the types of problems that persons with MS have and such. So back to your question about prevalence. If you look at the literature, and you got to look at it very critically, and much of the time the literature is defined as impairment. And so where someone is scoring very, very low on a given test or within a given area. So a good deal of...
Excuse me, but how do you define impairment?
Yeah. It's typically where a person is scoring very, very low on a test compared to their age peers, as we might say, or their educational people in a comparison group of their same age, maybe same education, and they're scoring perhaps maybe at the 5th percentile. Well, only 5% of the people would have scored in their appropriate comparison group below that level. So that's where we start looking at impairment and such. So many of the prevalence data, or how many percentage of individuals with MS have cognitive functioning, is based upon that notion, impairment. And so if you look at that literature, I think the rule of thumb has been about half of people with MS may have it. But the range can be about, from being precise, using 43% to 70%, probably based upon what you were talking about, Dr. Kraft, upon who's being tested, what kind of samples and such. But I want to go back to this idea about impairment, and that is, so if we think about someone scoring very, very low, maybe below what 5% of the population might score on a test, let's call that our definition of impairment. Well, many people with MS may not score in that range, yet at the same time have a decline in their abilities. So I think we like to think about, cognitive functioning if there are difficulties, both in terms of impairment, but also if we have someone coming in with really high skills, before their MS, and now they're having more effort in their daily tasks because of cognitive problems. They may have dropped down, not into the impaired range, but they may have declined. So I think it's important when we think about MS and cognitive functionings, persons may not be impaired, but they may have had a decline in their cognitive abilities. That makes life that much more difficult. So
A good example of that, recently evaluated a person whose leisure time activity was flying. This person had been a pilot for 25 years, and visual spatial and visual memory performances were at about the 15th percentile, 15th to 16th, in the context of an IQ that was at the 85th percentile. So, you know, even though that's technically low end of the average range or a little below, that was a very dramatic change for this person.
Yes.
I think that's a great illustration of that the person may not be impaired, but their abilities have declined from where you would expect them to be prior to their MS diagnosis.
And Dr. Pepping, you bring up something, or you allude to something, and that is that it may depend upon what a person does in their life as to whether a certain component of the cognitive testing will impact them. For example, a pilot who can't really remember and pick out things and you know, have visual spatial appreciation of the terrain is going to be really impaired, whereas there may be some people who that wouldn't really bother them very much at all.
That's right, because their day-to-day activities, even their work-related activities, may not require a significant spatial component, and they can do quite well on the basis of their verbal and other abilities. So I think one of the big themes is evaluating and treating the whole person. I think that's something that rehabilitation medicine and rehabilitation psychology and neuropsychology and neurorehab are all about. You know, appreciating them, their context, what they do, who they've been all their lives, and now who are they, what's the same, what's different, and what are we going to do about it as a team to work together.
I want the viewers to appreciate this, because I think these are very significant points, that it's not simply just taking a test and getting a number.
Right.
It's the appreciation of the subsets, the components of that test, and how they impact on the patient's life and what the patient needs to function well in their life as they've chosen to live it.
Yes.
As I also look through the literature and attend meetings on MS, I see various people proposing that they have very short and cheap and fast cognitive tests, sort of screening tests. Would you comment on those, maybe both of you?
Would you like to start? I'll have to just bite on a tongue depressor for a while.
I think it brings smiles. I think it brings smiles to both Dr. Pepping and myself when we hear that.
You start, Myron, and we'll go from
there.
there.
I think tests, very quick tests, where a person can come in for an hour or less.
Oh, I think less in some cases.
Maybe half an hour.
Yes.
Goes against what we're talking about, about this is a whole person that we need to evaluate, and it doesn't start or stop with cognitive functioning, and MS can have a variety of problems with regards to cognitive functioning. But as we said, that's not the whole story.
Right.
And the whole story is about taking in all the history, other factors are coming into play, depression, fatigue, and that we want to know about. And I think that's why neuropsychological evaluations take longer than just a half an hour. And not that I think so. That's why it should take longer than a half an hour, or because you want to take in the whole scope of the individual. And there's different aspects about cognitive functioning, and those small batteries only may be taking in one aspect of memory.
And maybe what's the common but not appropriate to that patient.
And
I know that Mary wants to say something here.
Well, I
can tell.
Mary always wants to say something probably, but I think there are times when a screening exam can certainly be useful. If you are a physician in a clinic setting and you have a patient who has MS, who's quite depressed, and you have some concern about cognitive performance, it may be that a screening exam of some kind could really identify a few additional areas above and beyond what depression would predict that would be a very good reason to send the person for a comprehensive workup. So I think in that, there are places where the screen can be beneficial, but certainly people with MS in general, especially because in Oklahoma they would say they look good from a galloping horse. They have these abilities. Or we can go back to the iceberg analogy, and you really need the comprehensive exam to look at everything that's below the tip of the iceberg. So.
I am so glad that you guys are part of our Western MS Center, because I really think you help us really do the best we can to serve patients in the Seattle region. And I thank you so much. I really do appreciate working with you.
Thanks,
Thank you,
George.
Dr.
It is really an important part of the assessment and management of patients with MS. I don't want you to giving up hope, because we're going to talk in a few minutes about management and how we can treat these things, but I do want to tease apart the assessment a little further. Would you, Dr. Goldberg, would you kind of overview common deficits that MS patients may have, if you can indeed say that MS patients have certain sort of signature of cognitive testing?
I think
or is that something that's you can't do, or can you?
I think we have to start with, a variety of things can occur with a person who has cognitive difficulties in MS. The damages in the brain can be, occur in a variety of areas. And so I think as care providers, as a physician or neuropsychologist, we have to be sensitive that, there could be a variety of different types of cognitive problems. That being said, I think the literature is very, very clear that there are some signature cognitive difficulties in MS that often comes up, and I think that Dr. Pepping and myself see in our everyday clinical practice. Probably the number one signature difficulty that a person has is information processing efficiency. Now, that's saying a lot. It's basically,
Thanks a lot. Yeah.
Yeah, it's saying a lot, but it's how efficient a person is in taking information in, their speed of processing. And in fact, if you look at, and I think about my cases that I see, and I think about the literature, it's probably one of the number one difficulties that persons with MS who have cognitive difficulties, not all do, but who have cognitive difficulties, that's one of the number one findings that we see, that the speed by which they process information is not as fast. And so the other thing that we see too is their attention span maybe shorter. And the last area that we see within this information processing efficiency is complex attention. So the ability to do mental multitasking seems to be poor or poorer. And I think that's in that category of difficulties in the information processing efficiency are the difficulties that we commonly see. The other area.
Can I interrupt you?
Sure.
And ask you about multitasking,
Yeah.
because I want us to kind of talk a little bit about what this is, and we'll get back to that. So I think this is key. I think multitasking is one of the things that you see early on, and it can be very difficult for MS patients. The common assumption, I think, is that multitasking is that you've got your brain doing simultaneously 2 or 3 or 4 things. I don't think that's correct, but correct me on this if I'm wrong. I believe it's more the ability to jump from one thing to another quickly and to have many things on the plate but still deal with one at a time, but still jump back and forth. Is that not correct?
I like that. I think that's how we function when we, that we jump from one things very quickly and such.
But you can keep them all active.
Keeping
keep
all on
the
the
balls
table
in the air.
and mentally on the table. And when those types of difficulties occur in this decreased efficiency is that people will say they're overwhelmed easily in their daily environments and such. And when they get overwhelmed, they kind of shut down a bit and makes
Makes it
matter,
worse.
makes it worse. And so that decrease in speed of processing, the problems with attention span and complex attention in everyday life, a person will commonly say, what happens, and they'll say, I get overwhelmed quickly. It's harder to make decisions, right on the spot and such, because I got so many things going on. It's hard to handle all those things I have to hold up in my head.
And when we say complex attention, multitasking is one of the forms of complex attention,
Right.
and it's the one that's most commonly disrupted. So.
I think the other, George, were you going to say? I think the other, a couple other areas that come up as signature kinds of problems for persons with MS, and one is memory. And memory.
By that you mean learning new things or retrieving old things, or both?
Well, it could be both, but primarily we're thinking about learning new things. And there's a particular pattern that we oftentimes see with regards to memory difficulties in persons with MS. And the number one thing is it takes more exposure, more repetition to learn new information. And so if you just hear it for one time, you may not get everything in. So, and if we asked you, like, several minutes, 20 minutes later or half an hour, that information may not be available to you right on the spot. So both immediate memory and maybe delayed memory is off. But the interesting notion in MS, which oftentimes occurs, if we give you hints, if we give you cues, it helps you to retrieve information. So many people will say that the difficulty in memory for persons with MS has to do with retrieval. Well, it may also be how you organize and get the information in and such, so maybe on the front end as well. But when we give you cues, you can see, boy, they had it in the memory and they just couldn't bring it up. So many people will say, it's on the tip of my tongue. It's right there. And all of a sudden you give them a cue and they have that aha experience. And they say, oh yes, that's what it is. And I think that's, if you ask many persons with MS who have cognitive problems, they'll say in their everyday life, it's there, I just need that hint, and I'm just a little bit more forgetful in that sense.
Some people without MS have that problem. You will walk down the street and see someone, what is that person's name? It may take a moment to retrieve it.
Well, and normal memory is not perfect memory. And that's one thing we try to remind our patients and ourselves
Yes.
of. Normal memory is not a perfect
not
memory.
perfect.
Yes, so I think the thing to keep track of is it a change for the person, and is it a change that goes beyond age-related or other, factors as causes?
That's very, very good. I think also that from a clinical standpoint, you talked about having a screening test or something in a clinic that for a busy clinician to give to a patient. I think that what at least for me seems to give information about this is how well somebody is doing in their gainful occupation in their home life and so forth, because I think increasingly, especially in this economy, to keep a job, people are being squeezed throughout the economy in all areas, and their employers are demanding more from them, and maybe faster working, and maybe doing several things. And I think that to keep a job, to keep working well, especially for a woman, and we know that almost 5 to 1, it's a female disease, MS. Think of the mother with 3 children, teenagers, or maybe younger than that at home, holding a full-time job with a husband who expects this woman to cook the meals, to clean the house, to sometimes mow the yard even. I am amazed, and some of these patients I have are my heroes, because I know they have cognitive problems because they come with all sorts of little yellow sticky notes and their notebooks, but they're functioning, they're working, they're doing well, and their employers think they're doing well. But I know how much effort they put into these things.
Right, it's costing them a lot.
Dr. Kraft, I think that word effort that you said makes it a courageous thing that they try to do in that scenario. In that, I think if you talk to people with MS who have cognitive problems, effort and how much more effort it is to do their normal routine comes into play, and how energy depleting it can be, and so it's harder for them. Everything it requires that much more being focused and taking effort to focus sometimes.
You mentioned that to a large degree it's the acquisition of new knowledge quickly or without repetition. And I find that that my patients in the clinic, I will maybe spend 45 minutes talking with them or so, and they won't remember many of the things I've said. So I've encouraged them, and I encourage all of you, when you go, all of you with MS, that when you go to your healthcare provider's office for your visit, take a little recorder with you and put it down on the desk and turn the recorder on, and then take it home, because you will listen to it, and I guarantee you will hear things that you'd forgotten. And your significant other will want to hear what the doctor said.
It's a fabulous idea, and those little digital recorders are not expensive.
No.
People can plug it into their computers if they want. When they get home, they can have a record of it. It's a fabulous idea.
Most of life is just hearing things just once, in our everyday conversations and stuff. And if we say that it takes more time to learn things, having a recorder makes so much more sense.
There's another thing that may help this, and that is getting a good night's sleep. because we know that the encoding of information seems to be done most efficiently during the slow wave deep sleep period, the sleep cycle. And I think all of us, people without MS as well as people with MS, will sometimes have many things going through your head, and you go to sleep and you wake up and they are a little more clear. It's as if my messy desk, somebody has filed things in the right place. So
We call it the restorative percolating effect.
That's right,
So
that's right.
Gets consolidated over time.
That's right.
I wanted to mention one other signature problem that we see in the literature on MS, and that's something, a big area that we call executive functions. And that area of ability has to do with a variety of things, like how well we problem solve, how well we think flexibly through things, how well we plan and organize.
Plan and follow through.
And plan and follow through. So it's a difficulty that may be less prevalent than we see with information processing efficiency that I mentioned before, as well as memory. But executive function seems to be comes up to be a problem for many people when they come out, and where we see it is in very demanding, complex settings or tasks, oftentimes in work and such, where they have to plan and organize well. It could even be in home life if it's a complex recipe or some type of complex hobby that you have that requires all those abilities too. So that's another area that often in the literature we see in our own clinical practice that we see people have difficulties with too.
I have a lovely, lovely patient who is just a wonderful person, and she will bring to the clinic some cookies she makes, and she told me one time it took her like 2 or 3 days to make them because she was making them and then she forgot if she put in something. She had to go over again, start over again.
Yeah.
And just a series of steps like that, and it just was really just amazing to eat those cookies because you knew how much love and devotion that person put into that recipe.
Sure.
I'd like to ask Dr. Pepping whether neuropsychological testing can show different patterns and different types of multiple sclerosis, because we do know there are different types of multiple sclerosis.
It can, Dr. Kraft, and there are many factors contribute, and people are unique individuals, but in general, if you see someone who has relapsing remitting multiple sclerosis and Dr. Goldberg or I are evaluating the person, we will see that very classic constellation of disruptions in speed of thinking, multitasking and complex attention, problems with memory getting in and getting retrieved, although doing a good job of storing it, and disruptions in executive functions. But you see preserved so many areas of intellectual functioning, basic verbal reasoning, it might be very, very good. Ability to solve visual spatial problems might be very good. Naming and verbal fluency, there's a whole range of skills that are just very well preserved in the person, let's say 10 years into the course of relapsing remitting MS. If you take a person of comparable age who has had primary progressive MS for 10 to 15 years, you certainly will see disruptions in the areas that Dr. Goldberg was describing, but you're also going to see a greater range of impairments and more suppression in some areas of intellectual function. So your person with the relapsing remitting MS might be scoring at the 80th percentile on measures of intellectual function, and they do have some of these mild impairments or disruptions. But the person with primary progressive MS who's had a serious disease course, their intellectual functions may have dropped from the 85th down to the 45th. So even though it's still within the quote-unquote normal range, we go back to the notion of it's not normal for that person. So you can see more pervasive, more widespread difficulty. And again, not always, not for every person who has it, but that's your concern.
This fits the understanding of the pathology of MS, because with relapsing remitting MS, it's an inflammatory disease that hits different spots in the brain, but leaves other ones completely normal, whereas primary progressive MS is more of a degenerative disease, more widespread neurodegenerative disease, not so much inflammatory component. And we see differences on neurophysiology, on somatosensory evoked potentials, for example. We can really, I believe we can do a good job of sorting these out from some of the laboratory tests we have.
Yeah.
Well, I think that was a really kind of excellent overview of testing and identification of how prevalent this problem is. It's a very, very serious problem, and of course in the management and rehabilitation of patients with MS, if they have a walking problem or spasticity, we can use antispastic medications or injections or baclofen pumps, canes and walkers and wheelchairs, and keep people mobile. But with cognitive impairment, we don't have braces for that. We don't have wheelchairs for your brain.
Yeah.
So are there things that we can do to help people with the cognitive impairment, Dr. Pepping?
Dr. Kraft, there are definitely things that can be done, and we don't want people to feel too discouraged by the discussion of the cognitive difficulties. Dr. Goldberg and I think it's fair to say our bias is knowledge is power, and if you understand what's going on, it gives you an opportunity to step in and do something about it.
Makes a lot of sense to me.
There is a vast literature on cognitive rehabilitation in other populations, such as people with traumatic brain injury. We're just beginning to see more of a literature published for people with MS in terms of the techniques have been tried. But when we add up our combined clinical years, that's kind of a scary thing to do, but I think 30 for me, and I won't even mention Dr. Goldberg's. But you know, you add all that together, and what we have seen over time is you can teach people to think more effectively. You really can.
That's important to know.
Yes.
How?
There are several different ways to kind of step into the process. It's very helpful to understand what is the upstream or underlying difficulty that someone has. You know, people will come to Myron and I and say, you know, my memory's shot. And we discover that, in fact, they store new information with 100% accuracy. They're having trouble paying attention, and they're very disorganized. And if we can treat the problems with attention and organization, then they find that they can memorize more effectively and retrieve more effectively. So the way that happens is to start off usually with a good neuropsych eval, and then to sit down and review what the difficulties are, and then to link up with a good cognitive rehabilitation specialist.
Who are these people?
Speech therapists, sometimes neuropsychologists, sometimes occupational therapists. And their job is really to kind of divide and conquer these problems into manageable bits and to train the person in techniques and approaches that will allow them to focus better and retain better and organize more effectively.
What are some of the techniques that people could use in these subset of areas?
Let's take the problem of being easily distracted. Some of the things that and maybe I could, as Myron was saying, you know, maybe I can give you the first caveat, which is one of the dangers of any presentation or manual on how to improve your thinking is most of us read through the whole thing, feel completely overwhelmed by all the suggestions, and don't implement any of them. So the one take-home message we would like to give from a treatment standpoint today is when you're hearing this presentation, just pick one thing that you are willing to do differently or try differently, getting linked up with a speech therapist and beginning to lay out the treatment plan. Otherwise, it feels overwhelming to try to do everything at one time. For people who have problems with attention, they're sitting at home, they want to pay bills. They have the radio going on in the background, or they are answering the phone. They have their iPhone on their hip, and it's vibrating because messages or emails are coming in. There are all these kinds of external distraction. The desk they sat down on is completely messy, and they are now being distracted by all the other piles of information on their desk. So what we would say, work with that person to do is throw a sheet over everything that's on the desk, you know, get that out of your visual field, and to just take one task at a time, turn off the phone, turn off the radio, turn off the television, pick your best time of day to do that. If you're fresh in the morning, don't try to balance your checkbook at 4 o'clock in the afternoon at the end of a long day. And follow a very systematic checklist for staying focused on what you're doing. You might have to say to yourself, I'm doing this now. We have internal distractions. We ask people to just jot them down on a piece of paper real quickly so they don't have to keep mulling over something that's troubling them. The idea is to block out external distraction, contain internal distraction, and follow a method or a checklist for the task that you're on. And drill and drill and drill that until it becomes a habit.
Many patients do have fatigue. It is the most common symptom, and I would think that fatigue could enter into this. How would they manage that?
There's a series of things that we ask people to consider for fatigue, Dr. Kraft. One is to certainly check with their physician to see, are there medications that are appropriate and beneficial that might allow them to have a little bit more energy or to sleep better if they're having difficulty with sleep. If they're depressed, to go ahead and treat the depression. We are very eager to see people do some form of exercise. All of the studies on exercise, even if people have weakness or limitation, if we can get a boost in the level of brain amines that support good thinking and all of the benefits mood-wise and otherwise from exercise, we like to see people do that. Ask them to review their nutritional habits, how they're pacing themselves during the day, to take breaks. You know, most people find it very satisfying to work for an hour without a break, but that doesn't necessarily work. So they have to have a system to break these tasks into 30-minute chunks and to work on it for 30 minutes and to take a break.
You know, I was just going to say, our brain is probably the biggest metabolizer of our energy, you know, when we're thinking through things. And the things that Dr. Pepping was talking about limiting distractions and all those things where you can just focus on one thing at a time, allows less brain activity and less energy consumption. I think that's a big help, aside from pacing and stuff. If you can start to eliminate the distractions in everyday life, it helps you focus, but also uses less energy to try to screen out distractions too, and such. I think fatigue is a huge factor that needs to be managed in all this.
You know, we've learned a lot about the function of the brain with something called FMRI or functional MRI, and that's a technique that looks at the blood flow in the brain as a response to different tasks like finger tapping or problem solving, and can identify where the blood flow goes up means that's the part of the brain that's working. And the fascinating thing about the human brain is it contains about 3 billion neurons, and each neuron can make up to 10,000 connections or synapses. And although with the loss of neurons in MS, you don't really grow new neurons, but you massively send out new sprouts from the neurons to make more connections. And the fMRI has shown that in patients who have lesions in one part of the brain, whether it be a motor activity or a cognitive activity, when patients produce that function, and it can be completely in the normal range, they've used a bigger part of their brain to do that. And I think that's part of the fatigue, and I think maybe that rings true from what you see, and that as we said earlier, to stay where you are with MS means you're working harder. And the more years go by and the more that the MS damages the nervous system, to stay there is even harder. But yet it comes on slowly, insidiously. People don't notice it. And I think that many people with MS probably learn to make corrections, adaptations, and maybe do some of these things you're talking about without even realizing the scientific basis for it. Would you say that's true?
I think that's exactly true, Dr. Kraft. And you know, a metaphor analogy I'm fond of sharing with my patients in terms of fatigue and what's happening with the neurons. You know, we know that neuronal sprouting, the dendritic sprouting, is occurring. And let's presume that these 3 billion neurons that Dr. Kraft is describing are our original forest, you know, the forest primeval. And we may lose trees, we may lose branches, things get cut down, some root systems die, but all of the remaining trees can leaf and twig and sprout. You may be able to develop regions of canopy, and it's not that we're not recruiting, you know, more of that to help us do what we need to do. but that there is some hope there, that if people will work on these kinds of tasks and use strategies and not give up, I think there's more and more evidence that for some people, those pockets of proliferation really help them maintain and carry well, you know, in a way that might not otherwise be possible. So to not be overwhelmed by the scatteredness or the disorganization.
I like that analogy of trees. I'm going to use it and credit you when I do it.
Thank you, Dr. Kraft.
But we also know that this is not a static thing in the brain. You give somebody a certain task and you see certain areas of the brain working. You give them another task and maybe at that time those areas are doing that too, because we've got the massive connectivity there that wasn't there before, and so information is switched back and forth, and the effort of neuronal functioning is switched back and forth. It's a very amazing dynamic reparative process, and I will say again that this dendritic sprouting is most efficient in slow wave deep sleep, and that is sleep is something that I encourage. I mean, it's one of the things, I think, one of the natural healing things that the body can do with cognitive impairment and MS.
Yes, to help restore.
That's right, that's right, that's right. What are your comments on this, Dr. Goldberg?
Well, I think the fatigue factor that we've mentioned, you know, all through our conversation is such a prevalent problem. You know, 90% of persons with fatigue, and I think that's a constant battle that people have, and a lot with what was said before, even in those FMRI studies about showing, you know, when a person with cognitive difficulties in an MS is trying to think through things, they may function at a certain level, you know, at a good level, but it takes so much more effort to do it. And I think I think it's got to be looked upon by persons with MS to pace themselves.
And you know, the other thing that's associated with managing fatigue from a cognitive rehabilitation standpoint is for people to establish routines and procedures that become automatic, you know, in their day-to-day life, to really have the day set up so that they don't have to keep thinking consciously every morning, now what am I going to do today, or what is it that's on the agenda today, that they really get those systems in place where they have it laid out during the week, what's going to happen on certain days, and they know before they go to bed at night that they're going to review their memory book, that everything in the backpack gets put by the front door.
Excuse me, what is a memory book?
A memory book is any device that a person wants to use to keep track of important information that occurs throughout a day. So it can be an appointment, it can be a birthday that you want to remember to send your friend a card. Anything that happens during the day that you want to remember needs to be jotted down or recorded and reviewed. One of the big problems we see is that people come in covered in those Post-it notes, or we won't look at anybody's computer screen if you have a frame around your computer screen covered with those. The problem is, once it's jotted down, how do you get it into the Bible, the memory book, whatever your source is going to be? It can be a smartphone, it can be a Palm Pilot, it can be a piece of paper, as long as it goes with you everywhere and you're reviewing it and making sure that there is a primary central source for all of the information that you need to be responsible for from day to day.
I think the key thing in this is there's one source and having one memory book, so the person starts to learn that that's where they put information in and that's where they go for it. And I like
what happens then if they can't find it?
That's a problem. But I liken to it learning a skill. I mean, for all of us here, none of us is writing down this information that we're doing right now, and I don't even know if the audience is writing this information down, because it's a real skill to learn it, to do things differently. Before, you relied on your memory to
it was automatic.
It was automatic. Take information in, I'm going to recall it later on. Now that's not as efficient. So doing it differently, writing it down. You know, it's easy for us to say you should write it down, keep that memory book with you, but it takes practice. And I think when you're with therapists, like a speech therapist and occupational therapist who are really doing, or a neuropsychologist who's doing work with you on memory skills, that's the number one thing you may find. The homework is really learning the skill to write information down in one source here and try to get into a habit. The habit before was not writing things down and trying to rely on your memory. Now it's a new habit, you know, to really rely, to write things down consistently. And sometimes we'll even enlist family members. Now, we're not there to have family members bug the individual, but help them and encourage them to write information down if they need to.
And when we say write down, we're very open to different techniques. It is humiliating for some people to be seen in public having to jot something down. I was just evaluating a person last week who said, I don't want to carry that. It's too embarrassing at work. I don't want the other people at work to see this. And so, you know, we were talking about other ways that this person could send themselves an email, pretend that they were making a call to their cell phone, but they were actually calling their own voicemail to leave a series of messages. And
That's
so
a great idea.
their procedure is, at the end of the day, they get home and they check in their personal email the messages they sent to themselves, and they sit down with the cell phone and they go through their messages and they write it all down then. And that was our compromise, because I wanted this person to carry something, and they said, there's no way I'm going to do this. I said, well, we have to find another way, and this is what we're working on right now.
I think that's great.
Is the cell phone and the email and end of the day review.
That's a great idea.
So there is one place that it's all there.
You know,
I
with
wish
the-
it was in that person's back pocket, but it's at home.
You know, with the electronic age and stuff, and one of the things that persons with cognitive problems in MS have is remembering to remember. And that is remembering to do something in the future. We call it prospective memory. An appointment might be remembering to remembering and stuff. And this electronic age allows us to have alarms and such to kind of go off and give us, okay, I got to do this at this certain time, or I have to do this, and this is an important, you know, appointment that I can't, you know, pass up. So having a memory book that we call it in general could also be, you know, some
Memory
type
device.
of a memory device.
Could be
that
a
allows
Google
us,
schedule.
that remind us. Because sometimes what a person will do is all of a sudden they're involved in something else, you know, and they get on a task. And we said, well, one of the difficulties is thinking flexibly and thinking about everything that's coming back. And sometimes you get so involved in something, you forget to look at your schedule, and you've forgotten about your schedule. Having an alarm system sometimes to bring it up on an electronic device can oftentimes be helpful.
I'm going to throw a word of caution out here, because it's fairly common among MS patients to come in with a memory, but they've actually learned to do this themselves, you know, over time, or somebody mentioned it to them, and I will be talking to them, and they'll be writing down what I'm saying, and I have had the sense that when they're writing down what I said a few minutes ago, they're not listening fully to what I'm saying now.
Right.
Which is why I had the idea that, well, let's make a recording of this, because I don't think patients with MS, I think that we all think back when you were in school and you were listening to lectures and you were writing it down. But I think with people with MS, it's really difficult to write down what you said and still be tracking on what you're saying right now.
Yes.
And I think
that's
that's
a great
a question.
point.
Just a question of just having a memory book and writing things down all the time. We have to use some of those dual tools, I think.
Yes. Yeah.
I think another cautionary point too, and why a therapist sometimes can be very helpful, is you may have a memory book, but it's kind of disorganized. Information is everywhere through it. It's really not, you know, scheduled. I think a therapist can oftentimes be helpful in organizing where information is at, so it's very easy to retrieve and much more useful and easy to use.
And in our
advice.
sessions, yeah, sorry, go ahead, Myron.
No.
Okay. You know, in our sessions, we'll sometimes say to people, I want you to pay attention to the discussion and participate, and I promise you, we will save time at the end to go over the key points and do, so that they're not in that divided attention circumstance and not able to be present for the key points. But then 10 minutes does have to be saved at the end of the hour, and then to help them write out at that point, you know, what are the points and where to put it in the book so it's not, you know, disorganized.
Yeah. Pick up on Dr. Goldberg's comment about reminders, about being alerted or something, and I understand that it's fairly easy with cell phone technology to, at least in some of them, to program them to ring at a certain time to remind you have to do this, and another time, you know, or here's a message, you got to do this, and you know, and that you can not only use it to put stuff into your own voicemail, but at least in some cell phones they can be programmed so as to alert you with certain things, or you can pre-alert them, or somebody can set them to do that, which I think would also be a very important thing to help.
It can be fabulous, and once again, the speech therapists that we have at UW Medical Center are wonderful, and there's a group of them whose specialty is higher level cognitive rehabilitation. And Dr. Kraft, they help people all the time with smartphones, cell phones. You know, bring in
That's right.
whatever your assistive device, your cognitive assistive device
That's
is,
right.
just bring it in. And Julie Brunnings and the rest of the gang will be very happy to set it up and help you design it so it's helpful.
Very, very good. Fatigue has been mentioned many, many times during this hour, and I just think how much has been developed over the past several decades in MS, and so much of our knowledge, we didn't have it a few decades ago, and I still have to go back and think that the first mention there, before 1984, fatigue was not mentioned in the literature for MS. And it was really
Wow.
research from this institution that published a paper in 1984 that was the first paper on fatigue in MS. And now everybody knows and agrees it's the most common symptom.
most
Up
common.
to 90% of people have fatigue. And I think it's fatigue is caused by different things in different people with MS, but a large part of this is, I believe, the fact that the brain is kind of an overdrive. That
All the time.
That you've got an 8-cylinder car, and you've lost maybe a couple cylinders, and those remaining cylinders have to work a little harder to keep up the horsepower.
That's a nice analogy for the cognitive functions as well.
Thank you. You may quote me on that, too. Well, thank you both, really, Dr. Goldberg, Dr. Pepping. Thank you very much for sharing your insights, wisdom, and helpful suggestions to the people watching this program. Cognitive impairment is a real thing, and as Dr. Pepping said, knowledge is power. Don't be afraid to talk about it to your healthcare provider, because there are things you can do about it. Thank you very much.